Good morning, good afternoon, good evening, depending on where you are joining us from. I am Fanny Ogu, a nurse epidemiologist, implementation researcher, an ambassador of the Geneva Learning Foundation, and a member of Immunization Agenda 2030 movement. Currently, I'm rendering independent immunization volunteer services to primary healthcare centers in the rural community of Delta State, Nigeria. I welcome you all to this webinar, a presentation by the Vaccine Beyond Borders, aka VBB, who are members of Boost Community Advanced Activation Training 2023 sets. The members are as follows: Lilian Mutua, Kenya; Dr. Mita Vashi from India; Aurangzeb Mugu from Pakistan; Wifrida Liwoyo from Zambia; and my very self, Fanny Ogu from Nigeria. The second slide. Yeah, please go on. Next slide. Okay, so please chat in the box as you are joining us. Chat in the box by way of introducing yourself, your name, your country, and with just one word, describe to us how you are feeling today. Are you feeling happy, excited, motivated to learn from what we have to offer? Thank you so much. Next slide. Next slide. So please mute yourself when you are speaking to limit background noise and feedback. Use the reaction button if you want to speak to us by raising your hand. We equally have the Q&A box where you can put in your questions so that as we progress, the facilitators will pick your questions and at the relevant time, we will address them. Thank you so much. Next. Okay, so now we go to the business of the day. To the business of the day. Okay. Cervical cancer is the fourth most common cancer among women globally. And we need to scale up access to HPV vaccination for the young adolescent girls towards prevention of cervical cancer and focus on the elimination initiative of World Health Organization by the year 2023. Today, we shall discuss facts about HPV vaccination, the importance of interpersonal communication skills, and tips for healthcare workers, especially the vaccinators, that will enhance demand of HPV vaccine to increase acceptance. Okay. We encourage you to listen attentively. Kindly let's share comments or questions on the chat as the discussion continues. We shall have a plenary towards the end of the webinar. During this live engagement, you also have the opportunity to join immunization professionals for experience sharing, networking to boost your knowledge and skills on how to tackle immunization challenges. Welcome, and let us discuss HPV vaccination for girls. I introduce you to the very first presenter by name, Lilian Mutua. Lilian, over to you. The floor is open. Thank you.
Good morning, good afternoon, good evening from wherever that you are listening to us from. Today we are going to talk about improving HPV knowledge among healthcare providers. My name is Lilian Mutua. I am a health promotion practitioner and lead in risk communication and community engagement. I hold a higher diploma in health education and promotion. I'm a registered nurse and also a member of the Boost community. So today we will be looking at improving knowledge for our healthcare workers so that they are able to continue negotiating for acceptance of the HPV vaccine. Next slide. Next slide, please. So we need to scale up HPV vaccine towards cervical cancer elimination. And we are looking at eliminating cervical cancer, the initiative of 2030, as recommended by World Health Organization. As we well know that cervical cancer is the fourth most common cancer among women globally. And in 2018, an estimated 570,000 women were diagnosed with cervical cancer worldwide, and 311,000 women died from cervical cancer. The infection is caused by the human papillomavirus, which when you get the infection, the woman will get cervical cancer at the cervix over a period of time. Although most of the infections resolve spontaneously, causing no symptoms, the persistent infection can cause cervical cancer in women. 99% of the cervical cancer cases are linked to persistent infection with either of the 14 high-risk human papillomaviruses, that is the HPV virus, which is transmitted through sexual contact from an infected sexual partner. The type 16 and 18 accounts for 80 to 85% of the cervical cancer globally. Next slide. Where are we now? 130 member states had HPV vaccine in their national immunization program. However, by the end of 2022, a coverage of 22% of the girls who were eligible to get the first dose of HPV vaccine from 16% in 2022. So there was a slight increase because some of the low income and middle income countries where most of the cervical cancer deaths occur still remain very poor. Each country should at least meet the 90, 70, 90 targets by 2030 to get the path to eliminate cervical cancer within the next century. That is 90% of the eligible girls getting the vaccine, 70% of women screened for cervical cancer, and 90% of those who get the infection going for testing, early diagnosis, and proper management. Inclusion of the HPV vaccine into the national immunization schedule will undoubtedly boost the fight against cervical cancer. The HPV vaccination is the best defense in preventing HPV-related cancers. By creating awareness, removing misconceptions, and myths of the cervical cancer menace can be effectively controlled, it takes the government, NGOs, and other concerned organizations to come together to fight against HPV and cervical cancer. And we as healthcare providers stand in this space. The diagram that we are looking at shows the transition of cancer from when the lady will have the normal healthy cervix, where we can see that the cervix looks very healthy, and that early stage 1B, where the cervical tissues have already been infected, and progressively up to stage 2B, where you are seeing that the cervical erosion has already occurred and they could be bleeding or discharge, and the cancer now spreads outside the cervix into the vagina and any other adjacent organ that is next. Next slide. Why the HPV vaccine? This is a rallying call to all of us that the girls who are eligible should get the HPV vaccine. The vaccine comes in 3 types. We have the Gardasil, we have the Gardasil 9, and we have the Cervavax. The HPV vaccine have been developed to protect types 16 and 18, which are the types that cause the HPV virus that causes 70% of all cervical cancers. The HPV vaccinations are recommended for females between the age of 9 to 14. At this age range with the biggest impact, because these girls, most of them have not yet started having their sexual debut and are not sexually active, so they have the chance of starting to get the immunity before they get the infection. The HPV vaccine contains antigens, but the very low amounts that cannot cause the disease. The body produces antibodies to fight the disease and develop immunity should the body come into contact with the HPV virus again. Next slide, please. So, who is the preferred target? This is the girl who will be between 9 to 14 years. And as we well know that we have not made a lot of progress because of the COVID-19 pandemic, where we know that most of these girls did not get their 2 doses. So the recommended doses for the HPV vaccine are 2, the initial one, and thereafter 6 months after the first dose, the girls get the second dose. But negotiations and discussions are continuing to happen globally for the introduction of a single dose for the girls. About the safety and the side effects, this is where we will have maybe a lot of myths and misconception from our target population and their intended decision makers. Over 15 years of monitoring has shown that HPV vaccine is very safe. Like any other vaccine or medicine, it can also have very minor side effects. The most common side effects will include pain, redness, or swelling on the arm where the shot has been given. Dizziness or fainting after the vaccination, including when the girls get the HPV vaccine, is common among adolescents and mostly because of hysteria. As the girl is smiling, let us also think about stopping the cervical cancer. Let us also continue to build trust with our communities. The next slide. About building trust, we must, as healthcare providers, have facts about cervical cancer. We should know that cervical cancer is the most common cancer among women under the age of 35. It develops as a consequence of repeated undiagnosed and untreated HPV infection, and it is not a hereditary disease. Cervical cancer can take several years to become established. With people who have a non-compromised immune system, it could take 15 to 30 years, but takes a shorter while for those who have immune compromised situations, where within 5 to 10 years, they could have cervical cancer. HPV vaccination is the primary approach in cervical cancer prevention, while for the secondary prevention, the ladies must have screening, treatment of precancerous lesions, and better management. Next slide, please. What is the global strategy of cervical cancer elimination? This is where we are going to look at how we are going to build trust, how we are going to build relationships with the communities, with our intended users, with the decision makers within our communities, and build networks for upscaling the uptake of the HPV vaccine within our communities. For vaccination, 90% of girls should be fully vaccinated by the age of 15. For those who are getting the 2 doses, we ensure that they complete the same within 6 months apart. For the women who are already sexually active, we ensure that 70% of all these women are screened using high performance tests by the age of 35, and as per what recommendation will be given by the service provider, and by the age of 45 and continually being screened. 90% of women with precancer lesions should be treated, and 90% of women with invasive cancer managed. And we see a lot of this because when there is invasive cancer, it also have the psychological and also psychoeconomical impact to the individual, to the family, and to the community. So we should all integrate into this rally on call and make sure that prevention is better than cure. We can still read more about the cervical cancer elimination initiative through the link that is being given there for World Health Organization, which clearly elaborates where we are at, where we want to move to, and what action should be taken at all levels. Next slide, please. So how are we going to activate our communities? First is by promoting the uptake of HPV vaccines so that the uptake is increased and there is acceptance for that target audience. Also, let us create cervical cancer awareness, because we must relate the two. Most of the time we have found people talking about the vaccine, and because we do not relate it to the cervical cancer disease, then people have had misinformation and misconceptions. What is our call as healthcare provider? We need to educate and empower communities to make informed choices. We need to build networks. We need to be the trusted information bearers. We need to stand in this space so that by 2030, we are able to eliminate cervical cancer as a global movement where you and I should be taking part. So we look at this and say that we need to look at trusted relationships between the healthcare provider. We should also make sure that we come together, build our communities together, look at the resources that they have to have these networks work, and at the end of the day, the girls will be able to be prevented from cervical cancer. Thank you, everybody, and for more information, let us look at the link and also continue on the chat. Thank you, and over to you, the moderator. Over to the moderator.
You are muted, honey.
So I will invite our next speaker, who is Mr.
No. Hello. Okay. Hello. Am I audible now?
Yes. Yes, you are.
Yes, you are.
Thank
Go
you
ahead,
very
you
much.
are.
All
Yes,
right.
please.
As I was saying, I was just appreciating Lillian for a brilliant presentation, highly informative. which will further boost the knowledge background of healthcare workers in the subject matter. In our world of today, the digital world, you often find out that patients and clients, before making consultations, before attending to any healthcare facility, they would have Googled to find out the symptoms, the diagnosis of whatever that is plaguing them. So at a time like this, we need to keep abreast with information, relevant knowledge as they relate to the areas of our service. Thank you once again. I hand over to the next presenter. That's Mugu. Over to you, Mugu. Thank you so much.
Thank you very much, Pani, and thank you so much, Boost team, for giving me this great opportunity. I am Aurangzeb Mughal, Deputy Director for Expanded Program on Immunization, Azad Jammu and Kashmir, Pakistan. I am basically a sociologist and public health specialist with more than 20 years experience in health communication, education, training, community organization, and community health, and MNCH services. First, good afternoon, good morning, good evening, good night, as per the time zone of everyone. Today, I will be speaking on the topic of improving HPV vaccine knowledge and communication among healthcare providers to accelerate acceptance. As my colleague Lilian has already discussed the HPV vaccine and its importance in the prevention of cervical cancer. Now we will discuss what interpersonal communication is and how it helps the healthcare providers to interact with patients, caregiver, and communities. So the interpersonal communication is crucial for healthcare providers to communicate information to caregiver. It is basically transfer of knowledge, information, ideas, and emotion among healthcare providers and parents to understand each other. It is two-way communication to address the parents' concerns, myths, and doubts regarding vaccine. Next slide, please. So the prime objective of this webinar is to build the capacity of our healthcare providers on interpersonal communication and boost the HPV and other routine immunization vaccine acceptance. Next slide, please. So the interpersonal communication is important for healthcare providers to build healthy relation with parents, communities, to enhance vaccination, to achieve shared goals. Next slide, please. There are different types of interpersonal communication, like verbal communication, as we are doing through one-on-one meetings, non-verbal communication, like gestures and body language, active listening, and written communications like email, brochures, posters to build the trust of the community. Next slide, please. While communicating with the parents and communities, we need good behavior, positive body language, and simple linguistic and good emotions to maintaining the interpersonal good relations and positive thinking toward the problems of the community. Next, please. There are some barriers of vaccine acceptance, like sometimes people living in far-flung areas and taking more time to reach health facility, arrive out of open hours. Sometimes vaccine goes out of stock. In some poor countries, the Ministry of Health and the parents could not afford the cost of vaccine. Also, the social and cultural myths are barriers in vaccine hesitancy, which need to be looked in. Next slide, please. There are different stakeholders like healthcare providers, private healthcare staff of private hospitals, social workers, community activists, local religious leaders, teachers, and community leaders, parents, and caregiver. These are the all people who are responsible to enhance the vaccine acceptance at the community level. Next, please. To accelerate this vaccine acceptance, identifying zero dose children, role of community is very important. I think without community participation and activation, we could not achieve the vaccine goal. So far, community activation, we need to learn community activation skills like storytelling, team building, and developing intentional relationship through one-on-one meeting with community leaders and different immunization stakeholders. Next, please. Through community activation, actually we are trying to identify the real strength of community, what resources they already have, and then we make team to mobilize the resources for change. They want to improve the vaccination status of children and how the community will achieve the set target within specific timeline. Next slide, please. So to engage the community, we can harness the power of storytelling to inspire and gathering individuals and community members. Through the art of storytelling, we convey our personal motivation for focusing on immunization, sharing our own stories while also addressing the collective challenges we encounter as a community, narrating the story of us by uniting our efforts. We can collaboratively devise solutions, local solutions to overcome these immunization obstacles. This is a very powerful tool to activate community. Next slide, please. Cultivating intentional and meaningful relationship within the community and nurturing these connections, we can uncover the common values and aspiration that bind us together. This process allows us to not only pinpoint shared objectives, but also to collaboratively address the obstacles surrounding us, vaccine acceptance. Through open dialogue and collective brainstorming, we can devise innovative strategies to enhance vaccine acceptance and contribute its improvement on broader scale. This approach, I think, emphasizes the strengths of community unity in tackling vaccine-related challenges. So, in conclusion, interpersonal communication and community activation skills can have a significant influence on improving routine immunization coverage and HPV through healthcare providers. Healthcare providers could ensure the vaccination schedule, and he or she is on forefront and play a crucial role in educating parents, caregivers about vaccine by providing accurate information. Effective communication between healthcare providers and parents can overcome the concerns and the rumor against vaccination. Thank you very much.
Thank you so much, Mugu.
Thank you. Thank you all.
Thanks for the wonderful presentation. What a great job. Communication is the bedrock of human relationship and connectivity. It's so important to life that even when we fail to speak, we are communicating. For us to reach out to the target population, we need to apply the interpersonal communication skill, which is of great importance for healthcare workers that will enhance HPV vaccination acceptance. In so doing, you are able to listen effectively. You'll be able to understand the parents and guardians that will give the consent for the vaccination before you are understood. Thank you for this comprehensive work, Mugu. I now present to you the next presenter, who is our guest speaker, Ms. Benda Kithaka, an executive director and founder of Kileli Health, an independent consultant, technical advisor, health advocacy on women's cancer, HPV vaccination, health communication, and community mobilization. Benda, you have the floor. Thank you.
Thank you so much, Fanny, and thank you for inviting me to this platform. I hope I'm audible. So as you've heard, my name is Benda Kithaka. I'm with Kilele Health, and I just want to appreciate the first two speakers, that's Lillian and Mungol, for speaking into what has become a passion for me and a purpose. I also want to appreciate Boost and the team Vaccines Beyond Borders for inviting me to be a speaker today. So as you've heard, my name is Benda, all those titles, independent consultant, technical advisor in HPV vaccination as well as women's cancers. Next slide, please. But I was not always this. I started out as a marketer, communications specialist, working in Toyota Kenya, selling high-end cars and motorcycles. That was before 2010. And then 2010, I was called by my brother in the evening. I remember that day very clearly because we had a launch coming up and I was on my office in the evening trying to wrap up the day, trying to see what that weekend was going to bring and looking at the plans for the launch. Sadly, my brother called, and from the voice, I could tell something was very wrong because what he said was, Njeri, nobody ever calls me that. He said, Njeri, I've not eaten for 3 days. And I listened. I was shocked. Why would you not eat for 3 days? I love food. My brother went on to tell me that he had been told my sister has cancer, and he was wondering how he was going to deal with being left with a small child, how he was going to deal with raising that child alone, and how he was going to deal with my sister dying. And my brother-in-law was not somebody that we spoke very often with. So for him to have taken the courage to call me meant that this was a weighty measure for him. For me, sitting on my desk at that time, I thought to myself, really, all I've heard about cancer is death. So are they saying my sister is going to die? But I've been known to be a troubleshooter. I've been known to be someone who thinks on my feet. So I told him, wait a minute, I need to think about this, but let me call you back in a minute. And of course, when I dropped the call, I called my gynecologist and I asked him, so my sister has been told she has cervical cancer and I don't know what to do, and she's in the village. And he told me, bring her to Nairobi so that we can have a checkup. That was a game changer for me. My sister came 2 days later to Nairobi. That was 2010. She started her treatment journey, and she started what was for me a life-changing moment. Because from the first visit, when the doctor did a speculum examination and said, I cannot quite see anything, we need to do a pap smear. And then he went on to do the pap smear. We were referred for a week after to come for the results. We came back. She was told we can see cervical changes, but not much. And therefore, it's not yet cancer. And therefore, what we need to do is treat you and observe. And in 6 months' time, we'll be able to tell you what's going on. At that time, all that sounded Greek to me because I did not have an idea around cancer. All I had was hearsay, the stigma in the community, and the fear that we hear. And so 6 months later, after a number of visits to the doctor's office, and after my sister had been treated and she recovered, my brother again called me. And that was now a year into, that was all 2020, almost 2021. And I thought with trepidation, what now? Why is he calling me? Why is it not my sister who is calling me? Only for him to share the news that my sister was pregnant. And literally, what I had always assumed about cancer all along changed in that moment. How is it possible somebody who had been told a year ago has cancer, has now preserved her fertility, is now well, and she now has a child in the body developing? It was unbelievable. Being a communications expert in corporate Kenya, I knew at that time that this information needed to move from my desk, needed to move from my knowledge to other people to understand. And so I started digging deeper and understanding more that cervical cancer is preventable. And that's when I realized in Kenya at that time, 2,500 women were being diagnosed with cervical cancer at late stages. They were being given 3 years waiting for them to get radiotherapy and chemotherapy. At that time, we had only one national referral hospital treating cancer in Kenya. I also realized this was, in essence, when we get a woman that late, it would lead to death, because ultimately, when you tell somebody, go home, wait for 3 years, and she's already having cervical bleeding, what exactly are we telling her? And so, together with a couple of friends, we started an organization. We went to communities every other weekend, talking to women, telling them to come get screened. As we got women screened, we started finding earlier and earlier cervical stages. But when we did, we referred them for treatment, and they would be treated and they would recover. And yet in the news, we would still see cancer deaths, cervical cancer deaths. In 2016, I took a bold step to learn health system strengthening, because I realized we were making changes for one woman who has been screened in our program, one woman who has been reached with the news that she can recover, one woman that will get the benefit of prevention. But what about the other women that our organization will never reach? And so, of course, with health system strengthening study, I got to get into the cervical cancer advocacy space. I joined technical working groups. My team and I would sit with the Ministry of Health, and that's how come we were involved in the second cancer control strategy planning, putting the voice of the community on the table. 2018, it was a brilliant year for me. The strategy had been launched. We had engaged the county first ladies. They were now our champions to start running with the story. And the government was planning for the HPV vaccine launch. And as you can see from that picture, in 2019, the first girl to be vaccinated was actually from a woman that I know personally. And that was joy for me. But 2019 came with also mixed reactions, because as we were planning for the launch of the vaccine, one of the women who was very dear to me, Rose Chiedo, died of a cervical cancer recurrence. And that was a stop moment. How is it possible that a woman who has been treated, recovered, can get a recurrence and die of it? I went into depression for 3 months, trying to understand what is survivorship. And that is where the story of Kilele came up, because Kilele started working with then cancer survivors and caregivers to equip them with the knowledge that they have a lived experience that they need to pass on to the community. Next slide, please. Sorry, before you move from that slide. And that is where you see that the first girl who was vaccinated in Kenya in the previous slide, that girl is a daughter to a cervical cancer champion in Kenya who herself is a cervical cancer survivor. Next slide. So Kilele was formed on the premise that we as survivors can come together, we as caregivers can come together and utilize our lived experiences to inspire communities so that they take on the challenge of preventing cervical cancer, improving uptake of HPV vaccine, giving women lived experience knowledge of where to go to get screened, where to go to get treated, how to take care of themselves during treatment, and therefore be able to recover and have dignity in recovery. And also take other survivors and walk with them so that we are sharing our experiences together, encouraging each other and giving each other hope. And in that, we formed Kilele, a family that is working with survivors, caregivers, to equip them with knowledge and skills on storytelling so that they can be able to utilize their lived experiences to give hope to their community. As I come here today, I know this call was supposed to be for healthcare workers, but I took the action to make sure that we also invite the community to this table. So you will see a number of people who are here who are either affiliated with Kilele or affiliated with the African Cervical Health Alliance, which is housed by Kilele. The reason being, we firmly believe we can end cervical cancer. Secondly, we firmly know that Africa leads the world with cervical cancer incidence, cervical cancer mortality, which is death. And we also firmly know that we have the tools the WHO has mentioned. Lillian mentioned earlier today, 90-70-90. We can prevent through vaccination. We can prevent through early detection, timely screening using high performance screening tools. And we can also prevent by treating and making sure people are adequately taken care of who have disease. I'm just about to finish. So why are we here today as a community? Because one, we want to appreciate the value of communications. I want to appreciate that if my brother had not called me, if he had sat with the knowledge that my sister had pre-cancer, today we would be talking of my sister having invasive cancer or even having died of cervical cancer. Secondly, when we engage communities, we are getting communities as valuable contributors to the journey. Survivors have lived experience of the healthcare system, and therefore they are better able to add value to making sure that the women in the community reduce stigma, reduce fear, and take up prevention, including the HPV vaccine. And lastly, we need to remember that we can do all things, but we cannot do all things at the same time. And therefore, when we work as a team, involve the community, involve survivors, and involve people with lived experiences as caregivers, we are better able to get communities empowered to prevent cervical cancer. We welcome you to walk the journey with Kilele. Thank you so much. Back to you.
Wow. Thank you so much, Brenda.
This is great.
This is wonderful. This is a story of self, story of us, and the story of now. Why do we need to intervene now? The motivation from the story of self is that call from her brother-in-law, and that prompted her to doing what she's doing. During the course of this training, we had been taught the skill of storytelling, public narrative, which Brenda has brought to bear. This is a demonstration of doing the talk, making it real. And we have been able to see the reason why it is necessary for the early detection of cancer of the cervix through screening, which is the secondary prevention pillar. The primary is the HPV vaccination, while the tertiary is the treatment. Thank you so much, Brenda. As we progress, I want to hand us over to the next presenter, that is Wilfrida with the Zambia experience. Zambia has introduced HPV vaccine. We are going to learn from her what is working and what is not working, so that those countries that are yet to introduce will be able to leverage on what the strategies that they can utilize, most especially like my country, Nigeria. Thank you so much. Wilfrida, over to you.
Thank you very much, Fanny. Good morning, good afternoon, good evening to everybody. And riding on the protocols observed, I'm Wilfrida Liwoyo. I'm bringing you an experience from Zambia. We started implementing HPV vaccinations to our girls in 2019. I'll share the experience that we had as we implemented the challenges, and of course, what we are doing now to redeem ourselves. The outline of the presentation is sharing the experiences, how we implemented the challenges we faced, the current happenings in the country, and moving forward, what have we planned and put in place as a country. Next. As already alluded to, as a country, we started the HPV vaccination in 2019 using the WHO guidelines, where it was said that 2 doses will be given to girls to be fully vaccinated. To start with, we targeted the 14-year-old girls, both in those in school and those in our communities. Of course, we organized ourselves, started implementing interventions, and then in our campaign, we started with the first dose. We registered the children in school and out of school. Out of the children, girls that we registered, we got 104%, which means that there were some girls that we had not registered in advance, we've covered. Along the journey in 2022, we had prepared to give the HPV vaccine, the second dose to the girls. And unfortunately, we did not do well. We were at 33%. Imagine from 104 to 33%. It was very depressing, and the challenges that we faced. We go to the challenges, we share the challenges that we faced. The first biggest blow that we had was COVID-19 pandemic, which started in 2020 in our country. It affected our program. The people were scared to come to the facilities, and the health workers were overwhelmed. Some girls who needed to get the second dose, when we followed them so that they're fully protected, we could not trace them because the schools had closed and some girls had gotten married. Some girls could not be traced completely, and some of them were already 15 years, above 15. So these were the challenges that we faced as a country. What have we done as a country? Now, looking at our challenges which we had, we have strategized. We are preparing for an HPV campaign this coming September 2023, using now the new WHO guidelines which says 1 dose, then the girl child is fully protected. And in this campaign, we are targeting girls 9 to 14 years, both in and out of school, so that we cover a lot of them at the same time. To our girls who are HIV positive, for them we'll continue with the recommendation of 3 doses. Second dose will be given after the first dose, and 2 months after the first dose, and then the third dose will be given 6 months after the first dose, so that we as well protect our girls with low immunities. Currently, we are registering the children aged 9 to 14 years in schools. The teachers are helping us to register the girls. We, as well as registering the girls in communities who are not in school, through door-to-door in the villages with the support from our community health workers. The next slide, please. We have developed our information, education, and social behavior change communication materials already. We've prepared ourselves adequately for social media, mass communication on TV and radio, the posters we've already done. And we are engaging stakeholders. These are community leaders, traditional, religious, the parent teachers associations in schools where these girls are found. We've already started engaging them so that we work together as a team. We are collaborating with other partners in EPI in expanded program for immunizations and those organizations that are promoting girl-child health. What have we done? We've come together as line ministries to work together. Ministry of Health, Ministry of Education, local government and community development and social welfare. We are working together. These are line ministries where mostly you find the age, girls with this age are found, and we are working together. This is what we've put in place. We are saying we are going to have a mass campaign to cover all these girls so that we protect our girls so that they are safe. We move on. What is happening? After we do this campaign this year, and the strategies we've put in place is we've learned them from the challenges that we had in 2022, where we had a 33%. We're expecting that we'll get 100% or above 90%. And moving forward as a country, by next year, would be saying we already covered our girls from 9 to 14 years, meaning starting 2024, we'll be focusing, targeting on the girls aged 9 years. So because we would have already covered the elder ones. And this is what we've done as a country. I hope some of you will learn from what the experiences we had, and we'll keep sharing as you've heard. And this time we are grateful because it's 1 dose. The girl child is fully protected. Next slide. What are we saying? We are saying we are not going to leave any girl behind as a country. We've heard the story from Benda, how they are working with the communities, supporting the women and the girls, and the men themselves who are supporting us through and through. And we've heard from what Lillian has said. Let's not leave behind any girl, let's work together. Thank you, Zicom.
Thank you so much, Zikomo Wilfrida, for that presentation. What I am taking home from there is collaboration. Collaboration all the way. So the next The next item on the agenda is question and answer. But checking the Q&A box, I don't seem to see any question and answer before our wrap-up. Is it that we have assimilated everything and nobody is asking any question? Thank you so much. Okay, all right. That's Adefunke Adeshino. Please, can you unmute yourself and ask your question quickly? Thank you.
Hello, thank you so much. I'm Adefunke Adeshino. I'm a public health physician. I'm a feed epidemiologist major. I've been an immunization working at the primary health care and for the past 16 years. My area of focus is maternal and child health, and immunization have always been my baby project. I'm one of the first liner for the Boost champion. Thank you so much. I would like to appreciate the group in general and the presenters from the lead, the team lead, and every other person that have spoke in your team. My thing is not really actually a question, but I would just want to try to call you into attention. Part of my thing I work around is HPV. In fact, I'm having a study on HPV now. So I just wanted to, to highlight some things. I think I joined earlier when the team lead is trying to introduce their, highlight the way they want to go about their discussion. I don't really pick that your outline concerning the objectives of the presentation. But in a way, you spoke about things, but don't forget that Boost platform, it's meant to connect, learn, and lead. I want to talk about the learning aspect of the the logo of this Boost platform. Don't forget that we invited different personalities, different people, different people with experience, different both health worker and non-healthcare worker to listen to this, because especially the researchers, it's not really meant for we, the healthcare workers, probably the planners, the implementers, the adopters, and the like. For the researchers here today, they may miss one or two things. And don't forget that the concept of this presentation is to present, to showcase our aims and objectives concerning a core aspect of immunization. Now, so I want to appreciate you for what you have said. So for the first person that have spoke is about objective, to define our objective so that it is specific. Whoever is listening will know where he's telling his presentation to. For the second speaker, I just wanted to mention something about, communication for whoever that want to speak about immunization in this new age and time. Epidemic is key to talk about. Now, you have spoke about communication, of which I really appreciated you bringing the knowledge of building a constituency. And but the aspect I will also want you to acknowledge is that, the segregation of this constituency, because whoever is listening like a stranger or a new person into immunization, or let's say the NGOs, just like our Bezeli. Sorry, I'm very sorry. I don't know if I pronounced your name very well. They also will pick a lot of things about strategy on how the immunization, because in this new age and time, epidemic is key. In fact, part of those things that cause reduction from that 15%, apart from the pandemic, we had a reduction in 2020 to the coverage of cervical cancer immunization, HPV immunization, is as a result of infodemic, myth and growth of vaccination. The way people believe what immunization is, what it can cause to their health, to their fertility.
Please, just quickly wrap up. Thank you, because of time. Thank you so much.
Thank you so much. So please, just about the infodemic aspect, we really need to dwell about it. So I appreciate the group. So, and then the Belisa, thank you for showing us the storytelling aspect, which actually, has highlights an open eye to us. Thank you.
Thank you so much. All your concerns are taken, and the aspect of interpersonal communication still comes in with addressing the concerns of the caregivers. And that is where we are going to dispel myths and misconceptions about HPV vaccination. Thank you so much. Now, I call on Dr. Mita to wrap up. Dr. Mita, over to you.
Hello all, I'm Dr. Meeta Vashi. I'm a medical doctor and a public health specialist who's working with SMO, working as a SMO with WHO India since more than 20 years. And I'm a Boost community member with special interest in immunization. Now, thanks for your patient hearing. And just to wrap up, in this session, we actually discussed about the need of HPV vaccine and the problem of cervical cancer. Then we discussed about, we heard an inspiring story of Benda, from story of self to us to now. Then we heard about the challenges from our colleague in Zambia on the implementation of HPV vaccine in the national schedule. And we also discussed about the importance and the technique of interpersonal communication. Even if we are from different countries, there is a big connect between us, and that is we all strive for immunization, strengthening in different capacities in our own areas. We may be doctor, nurse, communication expert, we could be an A&M, we could be a frontline workers, but one common thread is immunization, our passion for immunization. Some of the countries have introduced HPV in the national immunization schedule, and others are about to introduce it. It will be of interest to us to know that we already discussed that WHO has announced a global strategy for elimination of cervical cancer in 2018. And upon this announcement, the attainable targets were set for 2030, which is known as 90, 70, and 90 targets, of which vaccination is important when 90% of girls fully vaccinated with HPV by the age of 15 is our target for elimination. As we heard from our colleagues, that had introduced HPV vaccine in the program, but was hindered by COVID-19 pandemic, just like any other immunization services. As the dust is settling down on COVID-19 pandemic, we are calling everyone here and beyond to join us as we work towards together to make a difference in the lives of the girls and women by eliminating cervical cancer globally by 2030. So basically our journey begins here. This is not the end of the presentation. It's a beginning of learning more about HPV, more about communication and immunization, experiencing different methods of community activation, and engaging with immunization professionals across the world and immunization experts across the world. Would request you to join us in our journey together in boostcommunity.org. So this is basically this is beginning of an end of a vaccine preventable disease. So let's enjoy this journey. Thank you.
Thank you so much, Dr. Mita. Thank you for this wonderful rapport. What a way to conclude our presentation. So I call on Lillian to give a vote of thanks. Over to Lillian.
Thank you very much, Fanny. Thank you, the Vaccine Beyond Borders. We also thank the Boost community through Sabin, and also People Power Health, and all the listeners that were able to join in. And as Fanny has said, this is just the beginning. We shall be posting more of these sessions on our Boost community wall. So if you want to join the conversation on accelerating the acceptance of HPV globally, kindly join the Boost community, and we shall have more discussions there. You can also read other stories of other teams, what they are doing, how they have been managed to change their communities in routine immunization, in water and sanitation, reduction of water and sanitation diseases. And together as one, we can work towards a better future, especially for our children, so that our children receive all the intended and routine immunization. We are also going to look further into different issues I appreciate all the concerns that have been raised on the chat and also all the questions that have been asked. We shall ask Boost community to share the same link for those who maybe got in halfway or were interrupted and did not listen to the end. So I really thank you very much and want to wish all of us a pleasant time, and kindly, just like we have had a very brilliant time with the Boost community, kindly go on the Facebook pages, go on the Twitter space, and also look at their website and join the Boost community. Thank you, and over to you, Fanny.
Thank you so much. VBB, our slogan. VBB, are you in the house? VBB members, our health.
Yes. Our health,
Yes.
Madam, thank you so much, madam. We are listening to you.
Thank you so much.